OBC presented a free webinar on February 22nd, and it was hosted by our very own CEO, Dr. Eric Botts, who has years of experience in the field of optometry and is a specialist in insurance billing, coding, and credentialing.
So this is a presentation titled Value-Based Optometry, MIPS, and AOA more. And the presenter tonight is myself, Eric Botts. Been an optometrist for 25 years and currently own OBC, which many of you are clients for, and we appreciate your support and hope that we can continue to provide you great services in the future. So what we're talking about today is the merit-based incentive payment system, otherwise called MIPS. The one thing I can be certain about with this program is that it's evolving now and will continue to evolve in the future. So the information that we're going to cover today is what we know about the program as of right now, and probably in the next year or two it will evolve and change as time goes on. But it's going to start out with 4 weighted performance categories: quality, cost, clinical practice improvement, and advancing care information. And what this really is basically the changes that have occurred since initiating PQRS and meaningful use in the value-based modifier almost 7 years ago. So the MIPS is really just an evolution of those programs. One thing to note about the MIPS program is that it is budget neutral, which means that any benefits or incentives paid out to a particular doctor is going to be offset by a penalty or reduction that's going to be absorbed by another doctor. So there will be no additional cost to this program for Medicare, since it is budget neutral. And also note that any penalties or incentives are going to be applied 2 years after the performance year. So if the performance year that you're being measured is in 2017, then any incentive or penalty will show up in your reimbursement in 2019. Also note that your MIPS score will be available to the public, which potentially could affect a doctor's reputation. However, I don't see that it's going to be a real big issue, because personally I think patients choose their doctors for a number of reasons, and what the doctor's MIPS score probably is not going to be a big factor. So let's talk a little bit about the quality, which is similar to PQRS. You're going to be required to report 6 quality measures, which is actually fewer than what have been requested in the past. It must include either 1 cross-cutting, or better yet, 1 outcomes measure, in addition to 5 additional measures that you're going to be reporting. And the good news is that you have the potential here to strictly report on ocular measures only, because there are 6 ocular measures that you could report. Do note, though, that for each measure that you report, you need to see a minimum of 20 patients per reporting period. So if, for example, you don't feel like you're going to see 20 macular degeneration patients in the course of the reporting period, which after this year will most likely always be a 12-month period of time, if you're not going to see 20 patients during that reporting time, then that is not a measure that you're going to be able to actively pursue. And so if that's the case, then you may have to look at using some of the cross-cutting measures, which we'll describe in a lot of detail in a little bit. So of the 6 quality measures, you need to include 5 of the following: either primary open-angle glaucoma, the optic nerve evaluation, or a macular degeneration patient having a dilated fundus exam, or counseling the macular degeneration patient on the use of AREDS supplements. For your diabetic patient who has no retinopathy, there's the dilated eye exam. For the diabetic patient who has diabetic retinopathy, it has its own measure as well. And then there's the last measure for diabetes, which is communicating with the primary care physician. Any report that you have from your eye examination, you want to share with primary care physicians for that patient who's treating their diabetes, and that's actually worth bonus points. So I would recommend that you do perform that one if possible. Now, as I said before, you could also report one cross-cutting measure, which is from this list here of either documenting the medication usage, body mass index, closing the referral loop, tobacco screenings, or blood pressure screenings. However, if you do instead this outcomes measure, you actually get bonus points because the glaucoma measurement, and what this really is this measure is about is that you are reducing the pressure on the patient before you initiated treatment by 15%. And if you report this measure, you get additional bonus points for doing so. So I would encourage you to use this measure plus 5 of the other ocular related measures to get your 6 total. The 3 ocular conditions that are going to be considered for these measures are diabetes, age-related macular degeneration, and glaucoma. Each one of those have two measures. And then actually diabetes has an additional measure that you can use as well. So let's go through those measures individually. The first one being diabetic retinopathy, communicating with the physician, managing ongoing diabetes care, and you get additional bonus points for this communication with the primary care physician for the patient. These are for Medicare patients who are 18 years and older, diagnosed with diabetic retinopathy, and the measure says that you are dilating their eyes within the last 12 months, as reported with a 9.9 or a 9.2 level office visit. You'll use the CPD2 Codes 5010F, diabetic retinopathy communicated with primary care physician, and additionally G8397, which is a dilated fundus exam, was performed in documentation of diabetic retinopathy and or macular edema. The next measure is for diabetes mellitus, and this is for patients that do not have retinopathy. It is for Medicare patients ages 18 to 75, and once again, you report this when you are performing a 9.9 or 9.2 level office visit. And all it says is that you dilated their eyes within the last 12 months. The CPD2 code you're going to use for this is 2022F, diabetes mellitus, dilated fundus exam performed. The other 3 codes I have shown here are probably not going to be used by optometrists because these are more for telemedicine. The next measure is for macular degeneration, and this is that you are dilating the macular degeneration patient who is a Medicare patient 50 years and older, and once again you're performing a 9.9 or 9.2 level office visit, and it says that you're going to dilate them at least once every 12 months. And the CPT2 code you're going to use is 2019F for a dilated macular exam on a macular degeneration patient. The next measure for macular degeneration is counseling on ARIDS. It's for macular degeneration patients that are 50 years and older, performing a 9.9 or 9.2 level office visit, and you're counseling them on the benefits and or risks of the ARIDS formulation in the past 12 months. The next measure, that measure also, the CPT2 code is 4177F, which is counseling on antioxidant supplements. Now the next measure for glaucoma is evaluating the optic nerve. This is for your Medicare patients who are 18 years or older with diagnosis of glaucoma. You're going to perform a 9.9 or 9.2 level office visit, and it's saying that you need to look at the optic nerve at least once in the last 12 months. Also of note is that it does not designate whether or not it's a dilated pupil or not. So just looking at the optic nerve, whether it's with a direct scope or indirect scope, your choice, but every 12 months you need to look at the optic nerve. If when doing so you use CPT2 code 2027F, which is that you evaluated the optic nerve with or without dilation. The next measure is for primary open-angle glaucoma and checking the pressure on these patients who are Medicare patients 18 years or older with diagnosis of glaucoma. Once again, 99204, 92004, or any of the 99 or 92 level exams must be performed when you report this. You're going to use several different codes here depending on whether or not the pressure was reduced by or equal to 15% of pre-intervention level. If it was reduced by that amount, then you use 3284F. If it was not reduced by 15%, then you use 3285S, which just means glaucoma is uncontrolled. However, if you're going to use 3285F, you also want to use 0517F, which states that you have a plan of care in place. Some examples of a plan of care would be that you have them returning to check the pressure another day. You could possibly be adding or changing medications. You could order additional supplementary tests, or you could be consulting with glaucoma specialists. Now, just because the pressure does not go down by 15% does not mean that you are failing at treating this patient, because there's a number of reasons why the patient may not have a reduction in pressure. For example, if I initiate a patient on who I've diagnosed with glaucoma on a new medication, starting them on, say, a drop to use, have them come back a month later, and at that month's visit, their pressure is the same as it was at the previous examination. And after talking to the patient, I realized that the patient did not understand that they needed to use those drops every day. Maybe for whatever reason they didn't put the drop in the night before they came in for the examination, or the morning of, depending on the drop. That would explain why their pressure would be elevated or would not be any lower than it was at the previous visit. And if that's the case, then all you do is document your plan of care and have the patient either come back or change drops, whatever you decide to do. But when they come back at the next visit, you check their pressure again, and hopefully it will be decreased by at least 15%. So now some of the measures that you can look at that are cross-cutting, which are non-ocular conditions. Let's look at these in a little bit of detail. The first one is reporting the current medication list. This is documenting all of the medications that the patient is currently using. There's a lot of work involved here because you have to document prescription medications and over-the-counter medications, as well as any herbal medications they're taking or vitamins and supplements. Not only do you document what they're taking, but you also document dosage and how they're taking the medication. So all of that has to be well documented in the patient's file in order to be able to report the current medication list. You use only one diagnosis when you report this, and you can choose pretty much any of your diagnoses to report. You will report it at every visit. You will report it for Railroad Medicare and regular Medicare, but not the Advantage plans. And you report this when you're utilizing 99 and 92 level office visits. And once again, this is for Medicare patients that are 18 and older. The codes that you're going to report are G8427 if you have all drugs listed and routes administered documented. Or you can use G8430 for they were not eligible or it was emergency care. You could potentially use G8428 that nothing was documented. However, we're really getting to the point in these programs where you really should be reporting on the things that you perform. Eventually, I suspect that not performing the measure and using a code that says that you're not performing the measure is probably not going to be acceptable. The next measure that you could look at as a cross-cutting measure is for tobacco screening and cessation intervention. And this says that you're going to screen for tobacco use once within the last 24 months. You're going to give counseling if necessary, if they are a tobacco user. The easiest suggestion I can give you there is for anybody who's for example, smoking or using tobacco products. There's a direct correlation between smoking or tobacco products and macular degeneration. So you can easily tell the patient that continued use of tobacco products is going to increase their risk for developing macular degeneration. You can also, and this is what I often do, is I give the patient the 1-800 number for the state that they live in, there's typically a 1-800 Stop Now number that you can give the patient where they can actually call a government-sponsored program where they will have a live counselor who can also talk to them about stopping the use of tobacco products. Once again, this is for Medicare patients 18 and older, and you're going to report once per reporting period, and you're going to report using the CPD2 Codes 4004F if they are a tobacco user, or 1036 if they are a non-tobacco user. Measure 3117, screening for high blood pressure and follow-up, is also one of the cross-cutting measures that you could report. And this is screening for hypertension for Medicare patients 18 and older. You perform this once per the reporting period, and is not eligible for patients with prior hypertensive diagnosis. So if your patient has already been diagnosed with high blood pressure or is taking antihypertensive medications, they're not eligible for this measure. The CPD2 codes that you would use if they have normal blood pressure is G8783. If they are pre-hypertensive and you've scheduled them to come back for a follow-up, it's G8950. If no blood pressure was documented because the patient's not eligible, then G8784. If the blood pressure was not taken and no reason is given, it's G8785. And if the blood pressure was taken, it was elevated, but no follow-up was documented, you use G8952. So just to give you an idea of what's considered to be normal and abnormal hypertensive blood pressure readings, here are the normal is 120/80 or lower, and in that case you would not schedule any follow-up. However, if their blood pressure measured 120 to 139/80 to 89, then you would suggest they come back within a year, maybe suggest some lifestyle changes, some better eating habits, exercise, and that also maybe to suggest they go see their primary care physician. If they have a reading that's greater than 140/90, these patients should be rescreened within 4 weeks, definitely recommending lifestyle changes and highly encouraging them to go see their primary care physician. And then if they have a second hypertensive reading of greater than 140/90, also recommending lifestyle change for them. But these patients, they need to go see their primary care physician. That you need to emphasize to them, you may even want to call and make them an appointment, but they need to go get it checked out. The next measure is pain assessment and follow-up. You want to report and document pain level at each visit. For Medicare patients 18 and older, you only report it with one and any diagnosis code that you choose. Performing a 9-9 or 9-2 level office visit when reporting this measure. It's not necessarily going to be performed on patients who are presenting to your office for emergency care or have a mental incapacity that would not allow them to be able to be assessed for pain. Follow-up must include some kind of planned reassessment of pain and document future appointments. What they're asking you to do is use a standardized pain assessment tool. There's lots out there. You can use a numeric 1 to 10 grading of pain, with 1 being very little pain, 10 being very high pain. There's also the Wong-Baker FACES pain rating scale, which is what I have documented here for you to use as well. The CPD2 codes you're going to use for 131 are G8730. Pain assessment is positive, utilizing a standardized tool, and follow-up was documented. G8731 for pain assessment documented, negative or no pain. G8442 is the patient was not eligible. G8939 pain documented but follow-up was not documented. G8732 is no documentation of pain, no reason given. And G8509, you documented the pain, no documentation of follow-up with no reason given. Now there's 3 options for quality reporting. I highly encourage everyone who is an AOA member to register for the AOA More registry, and then if you have an EMR, it's going to be very easy to report on 50% of all patients. Now, this is different than if you're going to use reporting methods that don't include the registry. When you use the registry, you're going to be reporting on all of your patients. However, it's going to be much easier to do it this way because the AOA more registry and your EMR will do the reporting for you. As long as you document in the exam, and you're going to be able to use electronic clinical quality measures, the ECQMs, and these are going to actually be in your EMR. For example, for the diabetic retinopathy ECQM, you're actually going to have it right in your reporting of in your examination, where you will actually report what kind of diabetes, diabetic retinopathy the patient has, and whether or not they have macular edema. So you'll be just like documenting right in your exam using your EHR, and then it will automatically be reported for you, which means you do not have to use the F codes that I just listed for you for all these measures. And that's going to make it much easier for you when you don't have to report any more of the F codes with your insurance claims. So that's the easiest, I think, and the best way to do the reporting for the quality measures. However, if you don't sign up for the AOA registry, or where you don't have an EMR that is integrated with the AOA more registry yet, then you could use your EMR to just run quality measure reports and submit them through the CMS portal, which is how we've done the reports in the past. Or you can submit the codes on your claims and report on 50% of Medicare patients only. So this requires you to use the F codes that I just reviewed for you. And in doing so, you need to submit them for 50% of your Medicare patients who qualify for each one of those measures. You can report more than 50%, but you have to report at least 50% in order to get full credit. So the next measure is cost. And this is a category that actually is not going to apply to your 2017 score. It will come into play next year in 2018. This year, however, it will be 0% of your MIPS score. There's nothing to report on it because it's derived from calculations based on per capita expenditures on your claims data, and really there's nothing that you can do to control the cost category. If you want to know more about it, you can access the Quality and Resource Report at cms.gov. Clinical practice improvement activities is a new category. This is going to be used to demonstrate our role in public health initiatives. Using a registry such as the AOA More is going to make this easier, and it's the preferred reporting method. CPIA requirements are dependent on the size of your practice. If you have 15 or fewer doctors, you're going to be required to score 40 points for full credit under the CPI category. Good news is if you have fewer than 15 doctors or exactly 15 doctors, then your points are actually going to be doubled. So if you score 20 points, they will double that. You'll get 40 points credit. If you're part of a larger practice with 15 or more doctors, then you're going to have to score 60 total points. Reporting for CPIA for 2017 is going to be a very simple reporting of a yes or no. Either yes, you did score the 40 points, or no, you did not. So here's some examples of CPIAs, and this is going to be a category that's going to evolve over time. It's going to change, and so it's also nice that I think optometry is going to be able to play a part in how these CPIs play out and what they look like. But right now, this is the information we have so far, is that we're going to have CPIs that demonstrate practice patterns, that report that patients have 24-hour, 7-day access to their doctor. That's going to compare specific outcomes of treatments. It's going to show standards of practice care. It's going to promote adherence to treatment plans. It's going to have timely communication of test results. It's going to result in you engaging your patients and families in decision making. and also going to allow you to close the referral loop. So that is what some of the CPIs are going to be based on going forward. Now, the next category is Advancing Care Information, or ACIs. Now, this is very, very similar to what we've done in the past with meaningful use. The only thing that's going to change here is the scoring is going to be different, in that the scoring formula for ACIs is that you're going to have a base score that's going to be worth 50% of your ACI score, and then you're going to have a performance score that's worth 90%. Plus, you have the potential to get bonus points up to 15% for using the registry such as AOA more. So obviously, if you add up 50 plus 90 plus 15, that equals more than 100. And 100% or 100 points is the most that you can receive. So if you score more than 100 points, you're only going to receive 100 points as part of your score. Now, the reason that they're giving us the opportunity to score more than 100 points is because for some of the performance scores, it's going to be very, very difficult to get 100%. In fact, I suspect very few of us will get 100% of the performance scores. And that's because unlike the base score, which really is just participation, as long as you do the requirements for the base score, it doesn't matter how well you perform them, as long as you do perform them, you get the full credit for the base score, and that's 50% of your score. However, the performance score is based on how well you perform each one of the measures, and that's where you're probably not going to score 100%. And then, like I said, you get an additional bonus if you use the AOA more registry. Also, you're going to report the ACIs by running reports from the EHR and submitting them on the CMS portal. So let's talk about the ACI base score. That's worth 50% of your ACI score, and it's going to ask you to perform 4 measures. You're going to have to do a security risk assessment, and that's basically just analyzing the risk associated with your practice, with your computers, with HIPAA requirements. You want to make sure that you are taking care of your patient information and that you're taking care of it in a secure way. This is something that OBC will be able to assist with in the near future as far as performing this security risk assessment. E-prescribing, which I think we all should be doing, is also one of the measures here that you want to perform for the ACI base score, as well as the ability to provide patient access to their examination information, and then also being able to exchange information between your practice and other healthcare professionals in a very secure manner. So the ACI measures are going to be based on the fact that you will have an EHR in your practice. You cannot score any ACI points without utilization of an EHR. Now, the ACI Performance Score, which is worth 90%, is broken down into these categories: the Health Information Exchange, the Patient Electronic Access, which is providing patient access to the records and allowing the transmission, viewing or downloading of patient information by the patient. Also giving patients specific education on their ocular conditions, being able to perform secure messaging that's HIPAA compliant, and medication reconciliation so that you have an accurate reporting of all the medications the patient's using. And then the last category is not one that's going to be performed by optometrists, and that's the immunization registry. So the ACI Performance Score is actually evaluating how often you perform each measure. So if there's a total of 6 measures and they're worth 80 points, if one of the measures, say, is worth 20 points, let's just talk about the allowing portal access. And let's say 66% of your patients have portal access to their records. 66% of 20 points total is 13.2 points. So if all of your patients do not have portal access, for example, they don't have access to a computer. If that's the case, they're not going to be able to have portal access, which is going to count against your score. So this is why I say it's going to be very unlikely that you're going to be able to score 100% on the performance scores, because here's where some of it is actually put on the patient to do. So we've now covered all 4 of the MIPS performance categories. For 2017, the quality score is going to be worth 60% of your score. The advancing care information is going to be worth 25% of your score, and the clinical practice improvement activity is going to be worth 15% of your score, with the cost not being part of your score for 2017. However, that is going to change in 2018, and what I think is going to happen is that cost may be worth as much as 30% of your score, and your quality is going to be reduced probably to about 30%. So they are expecting you to score on a scale of 0 to 100 for the MIPS score. Now the good news is, for 2017, in order to guarantee that you do not receive any reduction in reimbursement on your Medicare patients in 2019, you only have to score 3 total points, which is a very, very low score, which is a very low bar that they have set for 2017, with the expectation that everybody's going to participate and everybody's going to score well enough to not receive any decrease in reimbursement. So the good news is, for 2017, the scoring that you have to receive is very low. However, I would encourage you in 2017 to go ahead and practice. Get good at this. Go ahead and report as much as you possibly can, so that when 2018 rolls around and your score is probably going to be more like in the 60 to 70 range, in order to not receive a reduction in your reimbursement, that you'll be ready to go. You'll understand how the program works, and you'll be able to hit that score. So there's 4 options to participate in the MIPS program for 2017. Option number 1, which is full participation, I would suggest that you all strive to do this. However, the pressure is really off for 2017 since they've set the bar so low, so that if you do not actually participate fully, you're still gonna do well enough to not receive any reduction in reimbursement in 2019. But if you're going to participate under the full participation option, you're going to participate for at least 90 days minimum. You're going to report 6 quality measures. You're going to participate in all 4 ACI base score measures. You're going to report 5 of the ACI performance measures, and report 40 points of CPI measures, and that will give you the opportunity to potentially receive a 4% pay adjustment. Now, there's no guarantee that you're going to receive that 4% pay increase, but it at least sets you up for the potential to. The other option that you could do is partial participation, where all you have to do is report 2 quality measures, or 2 CPI measures, or the ACI base score measures, plus any one of the ACI performance measures. And this will avoid a negative reimbursement for 2019, or potentially receive a minimum positive reimbursement. The next option is really just you want to participate and do the bare minimum to participate, but still not lose any reimbursement in 2019, to not take a hit on your reimbursement. And that is reporting 1 quality or 1 CPI measure on as few as 1 patient. If you can do that, you'll get your 3 points, and you won't receive a decrease in your reimbursement. Or there's option number 4, and that is just you're not going to participate. You're not going to report any measures, and you are positively going to receive a 4% negative adjustment for 2019 in your Medicare reimbursement. So some questions that I know people are going to wonder about is, do you have to have an EHR to participate in the MIPS program? And the answer is no, you don't. And specifically for 2017, you can actually do really well, because you can report all of your quality measures, which are worth 60% of your score, without using an EHR. You could do it all on paper claims if need be, or you could do it electronically through a web portal, but you can participate in 2017 without having an EHR in your office. Now, you cannot report any ACI or CPI measures without an EHR, so I will tell you that next year, when the quality portion of your score drops down to, say, 30%, you're not going to probably be able to avoid having a reduction in your reimbursement at that low of a score without having an EHR in your practice. So I think this year you can get by without it. Next year, you're going to want to have an EHR in your practice if you don't already. So we're going to summarize a little bit here on how to report your MIPS measures. First of all, the quality measures can easily be reported with your EHR, and if you are registered with the AOA More Registry, you can report it that way, or you can use the CMS portal. The ACI measures and the CPIA activities are going to be reported only on the CMS portal. Now, pay attention to the fact that for 2017, you won't report anything until 2018, probably starting January 1st and probably can run through sometime in March of 2018 to report for 2017 measures. So what's the least that you can do this year and not receive a negative fee adjustment? Well, as I said just a moment ago, all you have to do is report one quality measure on one patient. This is something that we can all do very easily. So there's really no reason for anybody not to score the 3 points and maintain full reimbursement from Medicare for year 2019. The AOA More, if you want more information, here is websites you can go to. Now, initially they said that if you are a non-AOA member that you might be able to set up the register for a yearly fee. My understanding is that that may not be possible, that maybe this year they're only going to allow AOA members to participate with the registry. So stay tuned for that. I would just encourage everybody to be an AOA member and utilize the benefits of being a member and utilize the free registry as a member. Now, let's talk about the exclusions, because for 2017, a fair number of doctors will not have to do anything in order to receive full reimbursement in 2019 on their Medicare charges, because a number of doctors will not be included in the program. And all this means is that you're not eligible to receive any incentive payments, but you're also not going to lose any negative reimbursement. So if you are a new Medicare enrolled provider, so if you're enrolling in 2017 for the first time as a Medicare provider, you're excluded from the program. If you charge less than $30,000 to Medicare during a 12-month calendar period, and that calendar period started September 1st of 2016 and runs through the last day of August in 2017, if you charge less than $30,000 to Medicare during that period of time, you're also excluded from participating. If you see 100 or fewer patients during the calendar year of 2017, you will be excluded from the program. And a very, very small percentage of optometrists, like 0.1%, who participate in accountable care organizations, will also be excluded for 2017. So what that means is you don't have to do anything, you don't have to report anything, and you'll receive the full Medicare reimbursement in 2019. So what do you need to do to get ready? First of all, I would encourage you to practice full scope optometry. Do everything your license allows you to do. Learn the codes and modifiers. If you're going to report using F codes, you're going to have to understand which codes, which F codes to use. You need to make sure your billing people are up to speed on what you want to do. So if you're utilizing OBC, let us help you. Make sure that you get credit for the MIPS program. If you're not utilizing an EHR, I would encourage you to look strongly at implementing an EHR system before 2018 begins, because it's going to result, if you don't have an EHR system in 2018, you will not score well in the MIPS program. I'm going to emphasize again that you're going to have to perform a security risk analysis, and once again, OBC can help you with that. We will have our security risk analysis program up and running in the near future. And make sure you're prescribing all medications by e-prescription, doing it electronically. You want to make every dollar count. That is all I have on the MIPS program. I am going to open it up here to questions if you have any. I'm going to unmute everybody, so if you have a question, feel free to ask it, or you can still type it in if you'd like. I do want to offer anybody who's on the presentation today, if there's anything that OBC can do for you, if there's any credentialing that needs to be done, you can contact Kenny. He's actually offering a discount this week for anybody who calls in from this presentation. We'll take 10% off of any of your credentialing that you may need to be done. So that's all I have. If there's any questions, feel free to ask or type them in. Thanks so much for joining us.
Thank you for watching. For any questions, call us, email us, or visit our website. We hope to hear back from you real soon.